Brain tumors in children most often occur in the posterior fossa. The most common benign brain tumor is a low-grade juvenile pilocytic astrocytoma. The most common malignant brain tumors in children are the medulloblastoma and PNETs. Common presenting signs in children include headache, vomiting, and papilledema. In infants, they may present with increasing head circumference because the sutures in the skull bones have not yet closed. The kids may also present with focal neurological signs and/or seizures just like in adults. Certain forms of genetic disorders like neurofibromatosis and tuberous sclerosis are associated with an increased risk of astrocytomas. The only way to know for sure the type of tumor is to do a biopsy. This is what the pilocytic astrocytomas look like. Pilocytic tumors are typically cystic nodules on radiologic imaging. On biopsy, you'll see bipolar cells with GFAP-positive hair-like processes. This makes some sense given the name of the tumor, since pilocyte literally means hair-like cell. The tumor may also have so-called Rosenthal fibers, which are swollen pink axons, not shown in this slide. Medulloblastomas are highly malignant and carry a poor prognosis. They are, however, very sensitive to radiation therapy, and they're among the class of pediatric tumors called small blue cell tumors. PNETs are a special type of medulloblastoma with a very low degree of differentiation. On biopsy, you can see cells with small hyperchromatic nuclei and scant cytoplasm with occasional Homer-right rosettes, in which the tumor cells are concentrically arranged around eosinophilic spaces. Ependymomas are uncommon glial tumors that arise from the ependymal cells lining the ventricles. They're usually slow-growing tumors, most commonly arising in the fourth ventricle. They characteristically form perivascular pseudorosettes. So if we break down that term, we have peri, around, vascular, for vessels, pseudo for appearing, and rosettes, that's the shape. Hemangioblastoma are characterized by lipid inclusions, which you'll see in the photo as the red staining, that occur amid delicate capillaries, along with intervening large cells that have foamy cytoplasm. If we break down the term, hemangio for blood vessels, blast meaning very undifferentiated cells, and oma. The main thing to remember is that these tumors are commonly associated with von Hippel-Lindau syndrome. What other tumors did we mention that are associated with VHL? So there were several: retinal angiomas, renal cell carcinoma, pheochromocytoma, pancreatic cysts, and also neuroendocrine tumors. Craniopharyngiomas are often confused with pituitary adenoma because they occur in the same area, the sella turcica. They are derived from epithelial cells of Rathke's pouch. Craniopharyngioma can cause similar symptoms to a pituitary adenoma by its compression of nearby structures. Compression of the optic chiasm causes a bitemporal hemianopia. Compression of the pituitary stalk may cause growth abnormalities, but these tumors can be distinguished from pituitary adenomas, as craniopharyngiomas often have cysts and calcifications seen on radiologic imaging. Also, the hormonal profile is different. In pituitary adenoma, you will see hypersecretion of one hormone, whereas in craniopharyngioma there is hyposecretion and there may be a mixed hormonal picture. There should be something in the question prompt to direct you to the right answer. Now let's discuss herniation syndromes. Why do things like benign brain tumors or hydrocephalus kill people? Well, it's because they increase the intracranial pressure, and this eventually causes herniation of brain tissue into other compartments, which results in the compression of certain vital structures, causing coma or death. Hernia is a general term that describes the protrusion of tissue through an area where it's normally contained. So brain herniation carries the same concept as an umbilical hernia or inguinal hernia. It's just that the structures are so much more vital in the brain. There are 4 areas where pressure can cause brain herniation. The first that we'll mention is under the falx cerebri. This is called subfalcine herniation. Falcine referring to the falx, and sub for underneath the falx. You'll find it here. The most dangerous sequela of subfalcine herniation is compression of the ACA, which causes frontal lobe infarction. And why is it the ACA? Well, think about the anatomy. A major trunk of the ACA runs along the rostral-caudal axis between the hemispheres, just above the corpus callosum. The second we'll mention is transtentorial herniation, when the pressure pushes the brain downwards. The brain can either move down centrally, thereby compressing the upper brainstem, or it can move horizontally, in which case it would compress the medial temporal lobe. In central herniation, it compresses the brainstem rostral to caudal. So if you look at an atlas, you'll find the structures in the midbrain, and you can think about the symptoms that would occur. A major portion of the midbrain is devoted to the reticular system, which mediates consciousness and arousal. So first, the patient becomes confused and drowsy. The nuclei of cranial nerve 3 are in the midbrain, so the pupils become small and react very little. They have so-called doll's eyes. Later, upper motor neuron signs appear, like bilateral Babinski, immature reflexes, and decorticate posturing. Eventually, the respiratory centers, which are also in the medulla, are damaged, leading to death. The uncus is the medial temporal lobe, so uncal herniation is herniation of the uncus into the tentorial opening. We'll discuss this more in the next slide. Lastly, the cerebellar foramen magnum herniation is the downward displacement of the cerebellar tonsils through the foramen magnum. What does this cause? Well, if you think about the Arnold-Chiari malformation, which is pretty much the same thing, you'll know the syndrome. The identifying feature will be paresthesias over the shoulders and loss of deep tendon reflexes in the arms due to compression of the dorsal side of the cervical spinal cord. Also, think about mass effect. The patients will have pain in the neck. They might also develop medullary signs. These would eventually lead to death due to impairment of the respiratory centers within the medulla. Now, when we consider uncal herniation, it's important to think about the anatomy in order to predict the syndrome. The pressure will injure the ipsilateral oculomotor nerve, so there is ipsilateral pupillary dilatation. This is the classic presenting sign of uncal herniation. Ipsilateral pupillary dilatation. The pressure may compress the PCA, so there is infarction of the occipital lobes, mediating vision. The contralateral cerebral peduncle is compressed by the laterally displaced midbrain, so it's actually an ipsilateral hemiplegia. Eventually, the pressure crushes the midbrain, leading to vascular occlusion of the arterioles and veins to the brainstem. These are called Durée hemorrhages. Once the midbrain and pons are compromised, stupor, coma, and respiratory failure ensues. Now we'll just briefly mention some differential diagnoses for brain lesions. Much of diagnosis in neurology is based on the focal neurological findings and radiologic imaging, so this is just a quick handy aid of some high-yield lesions. Now, what if you had a ring-enhancing lesion, particularly if that was in an AIDS patient? Here, your top idea is AIDS lymphoma occurring in the CNS. What about a heterogeneous appearing lesion with ring enhancement in a 65-year-old man? Maybe this person has new-onset seizures. Now, what are you thinking about? How about GBM, glioblastoma multiforme? And last, a uniform lesion attached to the meninges in a 40-year-old woman presenting with new-onset seizures? Alright, attached to meninges, so meningioma.